My name is Avi Spira. I'm a pulmonologist at Boston University, and it's my great pleasure to be chairing the session this morning on new technologies in patient care delivery. We've got three 20-minute talks. Initially, this was scheduled to be 3 talks back-to-back, followed by a panel discussion at the end. My understanding is the first speaker's got to leave immediately after their talk, and so we will take questions after the first talk, and then the latter 2 talks will be grouped together for the discussion. So without further delay, let me invite up our first speaker, Dr. Grillone from Boston University. He'll be speaking about, of the title, The Color of Cancer. Dr. Grillone.
So good morning, and thank you, Maria. I think she's still out there somewhere, and Bob for the invitation to speak. And I was asked to talk a little bit about spectroscopy and the work that I have been fortunate enough to be involved with in using spectroscopy to look at the management of oral cancer. And so just to give you a little bit of an overview, I'm going to give you a little bit of a background on spectroscopy, talk a little bit about the impact of anatomy in using spectroscopy in the oral cavity. I'm going to further talk a little bit about its use as a screening tool and for early detection, and then touch upon some future applications, including margin guidance, which is some work we're doing now, as well as its applications in other sites beyond the oral cavity, and the so-called sort of see and treat technology. And then finally, a little bit about imaging devices, which are slightly different from the spectroscopy technology that I'm going to talk about initially. And I just want to emphasize that I'm going to limit my remarks to the work that I've been fortunate enough to participate in at both the MIT Harrison Laboratory, as well as now more recently the BU Biomedical Optics Laboratory. So there are many other technologies out there that involve Raman spectroscopy and other types of spectroscopy, but I'm going to limit my talks to just the experience that I have had. So as all of you, I'm sure, out there know, oral cancer is a global problem. Even in the United States, there are 40,000 new cases every year and about 8,500 deaths annually. And in large part, this is due to the fact that most oral cancers are detected in later stages. And as we all know from data like this from the NCDB, the survival rate falls precipitously as stage advances. So early detection is the key. And what I want to offer up today is that spectroscopy may actually be one solution to the problem of early detection and has several key advantages over routine biopsy. So, for example, it's non-invasive. There's no tissue removed, unlike with standard biopsy. So processing in spectroscopy can be very rapid. There's potential for real-time diagnosis. There is even the potential for diagnosing and treating abnormal tissue at the same time. It is objective and can provide information not obtainable by histopathology, such as information regarding the biochemistry of the biochemical differences between tumor and normal tissue. It has the capability to sample a larger area of tissue, and it has the potential to monitor disease progression. So, as an example here, you see a picture up there of a patient with what looks like leukoplakia here. So in my mind, spectroscopy has several applications. One is, if you just sort of look at the normal tissue here, suppose this was a patient who didn't have leukoplakia, just had an entirely normal appearing oral cavity. Spectroscopy offers the possibility or the potential to detect cancer even before it's really visible to the naked eye. The second application would be in an example like this, where you see a lesion like this, And you sort of wonder to yourself, okay, is this a malignancy, or is this just a benign leukoplakia, as most of them are? And that would be another application for spectroscopy to distinguish between a benign and malignant visible lesion. And then finally, with known cancer, where you have a patient where, let's pretend for a moment that this has been diagnosed as a malignancy, and this patient is about to undergo surgical resection with a margin that might, be somewhere around here. Does spectroscopy have an application in that it could help guide where you actually take your margins to assure that you've actually resected the entire tumor? So a little bit about spectroscopy itself. It is the study of the interaction between light and matter. The most important spectral signals that are used in this type of technology are scattering, absorption, and fluorescence. It is useful for evaluation of surface tissues and has a range really of only millimeters. So it takes advantage of the fact that about 85% of all cancers actually do arise in epithelium. So this is just a schematic example of how the different components can actually help us. So scattering can actually give us information about collagen density and concentration, as well as keratin. It could also give us information about subcellular components, including nuclei and mitochondria. Absorption can give us information about some of the strong chromophores in tissue, including hemoglobin, tryptophan, keratin, and melanin. And fluorescence, where light is absorbed, as you can see here, but later emitted at a different energy, can give us information about those intrinsic molecules that actually fluoresce, including things like NADH, collagen to a certain extent, FAD, and tryptophan. So as an example, in carcinogenesis, we often see loss of basement membrane, especially in the transition from dysplasia to carcinoma in situ. This might be reflected in reduction in collagen fluorescence and scattering signal in spectroscopy. In carcinogenesis, we also see increased metabolic activity, which might be reflected in increased NADH fluorescence. We also often see angiogenesis, which may be reflected in increase in hemoglobin absorption. And finally, we might see in carcinogenesis increased density of nuclei with cellular proliferation, which would be reflected in increased magnitude of scattering because of the increased density. So the first opportunity I had to work with spectroscopy was in collaboration with the Harrison Spectroscopy Lab at MIT, as I mentioned before. And this was the device, the proprietary device that they had developed, and it looks fairly complicated. And I show this cartoon just to show that there were sort of two excitation light sources that then filtered into this fiber. This is actually a schematic, a cross-sectional schematic of the fiber, which we'll see again in a second. And this is the actual physical device. It's almost the size of a small refrigerator. And this device, I'm going to just show you the probe here, has a excitation fiber that sends light down, and then two collection fibers on either side of that central fiber. And here you can see another cartoon that shows it a little bit better. Here is the excitation fiber, and these six fibers around the perimeter are the collection fibers. So they collect the light that comes back out of the tissue. And this is how the fiber is used clinically. It's just held by hand. It's put up against tissue with a light touch. This technology we used probably back in the mid-2000s, and it was pretty fast, but required probably 10 to 15 seconds to get a reading. And it was a relatively complex device. It actually collected 3 types of spectroscopic data. Diffuse reflectance spectroscopy, which gave us information about morphology and the biochemistry of stroma. Intrinsic fluorescence, which gave us information about local contributions from things like NADH and collagen. And light scattering spectroscopy, which gave us information about nuclear size and density and distribution. So the first study was actually on healthy volunteers with no visible lesions in their mouth. And the goal was really to evaluate the impact of various anatomic sites in the oral cavity on the spectral properties of oral tissue. So we divided the oral cavity into about 9 areas, which are outlined here. We included tonsils for completeness, but that's not one of the areas that we looked at. So you could see we divided the oral cavity into dorsal tongue, lateral tongue, ventral tongue, buccal mucosa, floor of mouth, retromolar trigone, and then hard and soft palate and gingiva. And we had 79 volunteers, and were able to obtain 710 spectra from those 79 volunteers. And what we found was that the complex architecture of the oral cavity is reflected in the spectral parameters that we extracted from the various sites. And as you might expect, the keratinized sites, hard palate and gingiva, are easily distinguished from the non-keratinized sites, just primarily due to the thick keratin layers there. In the similarity score analysis, so in order to be deemed similar, they needed to achieve a score of greater than 10, revealed 3 pairs of spectrally similar anatomic sites. And those were the buccal mucosa and soft palate, which you might guess just from the consistency of those areas. Flora, mouth, and ventral tongue, again, makes sense. And then the 2 keratinized areas, hard palate and gingiva. So then we moved on to a patient study. And the goal of this study was to really develop spectroscopic-based diagnostic algorithms to distinguish normal from abnormal mucosa and benign from malignant or dysplastic lesions. So we were trying to figure out if we could distinguish between healthy mucosa and visible lesions using spectroscopy, and benign and with a visible lesion, could we distinguish between a benign and a dysplastic or malignant lesion. And we had 64 patients, 64 subjects enrolled, and were able to obtain 87 spectral readings. And the way we did this was for each patient that came in with a cancer, we took a reading with a fiber. We then scored the area directly where the reading was taken from with a small 2 millimeter punch biopsy. And then we took a slightly larger punch biopsy and surrounded the scored area and took a core of tissue like this. And what we found was that healthy mucosa could be easily distinguished from a visible lesion, particularly when the diagnostic algorithms are applied to either those similar sites that I mentioned or to single sites. Not so much clinically relevant, but important proof of the concept that this works. And then the second thing we found is that benign lesions, so with a visible lesion, benign lesion could be distinguished from a dysplastic or malignant lesion using diagnostic algorithms for lateral tongue alone or for the floor of mouth ventral tongue pair. And perhaps most important is what we found is that using a single diagnostic algorithm for the entire oral cavity is not really effective in distinguishing benign from malignant lesions. And again, intuitively that makes sense and really just underscores the fact that the oral cavity is such a heterogeneous area. So I just want to spend a few minutes now talking about some future applications. One area that I've been very interested in is real-time assessment of surgical margins for the presence of dysplasia and cancer to help guide resection margins for the surgeon. And this is a study that we're undertaking now, and this is through the Biomedical Optics Laboratory at Boston University, which is run by Irving Biggio. And you can see this technology is a little bit different. It's not as complex as that other device, the previous device I showed you. It utilizes just one technique, and that is elastic scattering spectroscopy. Physically, the device is a lot smaller. We can actually, the one we're using is even smaller than this. It's about so big and can sit on the top of a table and be brought into the operating room very readily and used to take readings. And so this is an ongoing study that is almost near completion. And this is funded through an NIH grant, and we're attempting to accrue 40 subjects who are undergoing resection for known cancers. And the plan is to take about 6 to 10 biopsies per patient. So our goal is to get about 240 to 400 biopsies. And just the schematic just sort of outlines this would be the actual visible tumor when the patient is going to have resection. This would be all normal appearing tissue. This would be the surgical margin right here. And what we do intraoperatively before the resection has begun is we use the same technique of punch biopsies to take a spectral reading and then a biopsy, typically some from the tumor, some from right at the margin, with the hope that we're actually will get some dysplastic, visibly normal but dysplastic tissue, and then sequentially take some biopsies further out so that we get a good distribution of known cancer, visibly normal but dysplastic tissue, and then hopefully normal tissue. Another sort of future application I wanted to mention is the fact that the fiber-based technology can actually be used to reach beyond the oral cavity. This is an example of using the MIT fiber just to take readings off of an actual vocal cord. And one thought that we had was that because we are able to actually treat many dysplasias and small malignancies in an office-based setting using fiber optic technology like this, is that it could actually be coupled with the therapeutic laser technology. So for example, you'd see a patient in clinic, you can actually make the diagnosis using spectroscopic fiber-based technology, and then use similar fiber-based technology to treat that lesion. And then lastly, I just want to end with the application of wide field imaging. So one of the limitations of using fiber-based technology is that you can actually miss lesions. So, so for example, here, if this is diseased and this is healthy tissue, particularly if this is invisible disease, depending on where you place the fiber, you actually may miss disease if you're using this as a screening tool. So one of the technologies that they were working at MIT is essentially using a virtual probe, where the probe is up here and is bounced off a mirror, and the mirror can actually be moved back and forth to actually cover a wide array of tissue. So I'm just going to use this little cartoon to demonstrate how that would work. So if you had a virtual probe that moved very rapidly, it could take point measurements, but across a wide area of tissue, and ultimately give you a reading from that entire square, 2 centimeter square area. And that has importance and is intriguing to me because that would be a useful tool for actually screening for pre-malignancies in the oral cavity. And this final is just a picture of how the folks at MIT were able to take this ex vivo sample of colon cancer and actually correctly and accurately diagnose the cancer, which is outlined in this yellow area here, using that imaging technique. And so I think I'm just out of time. I'm going to just hold up this slide, and I'd like to acknowledge everyone, in particular Michael Feld, who passed away a few years ago and actually was a big influence on me being involved in spectroscopy at the MIT lab, and Irving Biggio, who runs the biomedical optics lab at Boston University. So thank you, and I'm happy to take any questions.
Okay, as I said, we'll open the floor to questions after this talk. And maybe just to get started, I'll try to use the microphone over here. Great. I think that's a really interesting technology, as you said, with a wide range of applications, from screening to diagnosis to surgical resection. I wonder if you can comment a little further on the diagnostic application. You mentioned that right now you don't have an algorithm that would be distinguishing benign from dysplastic or malignant epithelium in the mouth. If you were to have that, would you believe that you can get high enough sensitivity that a physician would then not do a biopsy, since that's the gold standard here, and it's relatively easy to access the tissue for biopsy? Is that ultimately where this application resides, in avoiding unnecessary biopsies?
So, so ultimately, yes. I think everyone in who is in the field of spectroscopy is very cautious to say, at least now, that it really would serve more as a guide to biopsy. So, in the case of diagnosis, if you were monitoring someone who had high risk factors, smoker, drinker, and had sort of, inflamed looking mucosa but no visible lesion, could you use that technology to decide when, and perhaps more importantly, where to biopsy? Ultimately, could it replace, pathologic, histologic diagnosis? Possibly. I think anyone, who is a pathologist or who, or a clinician will tell you that even pathologic diagnosis is somewhat subjective. So, when you're looking at dysplasia, you send a specimen with moderate dysplasia, and some people will, you send it to 100 pathologists, 50 will say it's moderate and 50 will say it's mild. And so it's not exactly an exact science, it's still subjective. So this may actually turn out to be ultimately more objective than histologic analysis.
Let me just follow that up with a question then about, you didn't mention the application of prognosticating. So as you said, these pre-malignant lesions, their behavior is somewhat sporadic, difficult to predict clinically. Do you see this technology potentially not only diagnostic of benign or pre-malignant, but also within the pre-malignant group predictive of biology and future behavior?
That's a good question, and I'm not sure I know the answer to it. It does give you enough information about not only the histologic changes that a pathologist would see, but some of the biochemical changes, and to the extent that those were predictors of how the cancer was going to behave, I would imagine that it has that type of potential.
Other questions? Please, come on.
Thank you for a phenomenal talk. So my question is, would you please comment on the specificity of this technology in terms of how to differentiate between a real cancerous or a real dysplastic lesion versus just an inflammatory condition that we see in the oral cavity? Because there's a high chance of false positive results with these technologies.
So I've talked about a few different technologies, but if you look at the literature, most of the specificities that have been quoted for this kind of technology is usually in the 80 to 90% range.
There are no further questions. Thank you very much, Dr. Grillone. We're going to move on to the second speaker today. So my pleasure to welcome Dr. Margalit. She's an assistant professor of radiation oncology at Harvard Medical School. The title of her talk is Advances in Radiation Therapy for Head and Neck Cancer.
It's my pleasure to be able to give you all an update in advances in radiation therapy in head and neck cancer management. And we have a diverse group of clinicians and researchers here today, but just to give you a brief context, radiation therapy plays an important part in the management of head and neck cancer. It is, management of head and neck cancer, and the treatment of it is often a tri-modality approach involving surgery, chemotherapy, and radiation. And radiation is often used after surgery in the adjuvant setting or in the definitive setting as the curative modality with or without chemotherapy. So today I'm going to focus on technological advancements in radiation therapy. A whole separate talk could be had on how radiation is being used in combination with systemic therapy. But today we'll talk about technology and how it's being used to improve the therapeutic ratio in head and neck cancer. And these technological advancements are occurring in the context of two general themes in head and neck cancer management, one of them being de-intensification and trying to select which patients are appropriate for de-intensifying treatment. And in terms of radiation, that means how to maintain oncologic outcomes while reducing radiation dose and reducing the amount of normal tissue that's irradiated. The other major theme is intensification. Some tumors still have poor outcomes, and in that setting, the goal of radiation is try to identify which tumors may be resistant to radiation and potentially should be dose escalated, while also trying to minimize side effects. So the central goal of radiation is to really improve cure, but to increase conformality of the dose around the tumor and reduce the normal tissue that's irradiated. And I parsed the talk into two general themes, one being how we're integrating diagnostic and functional imaging and radiation planning, using image-guided radiation to minimize the margins of daily setup when we treat patients, and adaptive replanning. And the other theme will be in novel methods of radiation delivery and types of radiation. I'll talk about IMRT, stereotactic radiation, and particle therapy. So one major change has occurred in head and neck radiation, and that has been the shift from conventional radiation to intensity modulated radiation, or IMRT. With conventional radiation, as shown in this diagram, the radiation was often given via simple large portals coming from either side of the patient in lateral fields, and then a central and anterior component. And there was really limited ability to shape the radiation dose and curve it around the normal tissue. With improvements in software design and in engineering of the actual linear accelerators, which are the machines that deliver the radiation, there's been a shift from these simple portals, shown on the left, to radiation coming from multiple beam angles. Each of those beams can be dynamically shaped, and the fluence and the intensity of the beam can be modulated as it goes around the patient. And that's allowed for much more conformal treatments. With IMRT, the radiation oncologist almost plays a larger role in outlining very carefully what should be treated and what should be avoided, and designates a target dose to the areas that need to be treated, and also designates how to minimize dose to the normal tissue. There can be a lot of variability in IMRT planning, and on a national and international basis, the radiation oncology societies have really tried to educate practitioners across the board. One example shown on the left is a patient that required treatment to the draining lymph nodes. Now, everything encapsulated in the blue received 60 gray. And for this patient, the central midline swallowing structures weren't designated to be spared, and the patient developed a stricture. On the right, the patient also required treatment to the nodal chains, and as outlined in blue, you can see it's actually sparing the midline structures. The upper esophageal sphincter got a much lower dose, and the patient did not develop a stricture. IMRT has also been used for parotid-sparing, and here is another example. On the left, you can see treatment of a nasopharyngeal tumor, which is outlined here in red. And here, the radiation was given via the traditional approach where the radiation came from both sides and necessitated going right through the parotid glands, which are one of the major salivary glands. And these patients would get horrible, horrible dry mouth. On the right is the IMRT plan, where the dose is specifically shaped off the parotid glands, which are right here. And also, you can see a lot more ability to shape off the spinal cord. You can also note that there is some dose exiting through the oral cavity. So there are certain situations where IMRT may give more low to medium range dose to the oral cavity than in the non-IMRT era. And at Dana-Farber, we are enrolling patients in a prospective cohort study, a multi-institutional study, looking at dental outcomes after head and neck IMRT. There have been 3 randomized trials showing that this ability to spare normal tissue translates into meaningful benefits to patients. 2 of these trials were in patients with nasopharynx cancer. One of them was oropharynx and hypopharynx, and compared patients that received conventional radiation, those simpler techniques, to those that received IMRT in a randomized fashion. And all trials showed that with IMRT, there was better salivary flow and either better observer or patient-reported quality of life. What was also important through these trials is that while the radiation is getting more conformal and molded around the tumor, that there was not a significant increase in local recurrences. Because as you're getting more conformal, one has to be concerned that there's a possibility of missing tumor. And that did not seem to be the case in these tightly monitored settings of trials. As we're getting more conformal with our radiation techniques, it becomes that much more important to know exactly where the tumor is and outline it properly so it can be appropriately treated. And many clinics are using deformable registration algorithms to fuse pretreatment MRI or PET to the radiation planning CAT scan, which the whole radiation plan is based off. And here is an example where you can see in panel A, a radiation planning CAT scan, and then panel B and C, the pretreatment MR and PET being fused, and how it did affect how the tumor was outlined as shown by the different colors. Now, there's not one standard of care image which is going to necessarily give us the exact answer, but they're all very complementary in terms of delineating the tumor. Taking one step further, many clinics are evaluating the use of actually doing the radiation planning using an MRI and PET, rather than a planning CAT scan where you're deformably registering image. You're actually acquiring the planning scan on an MR or a PET scanner, which may avoid inaccuracies due to deformable registration or variability in patient positioning. There are specific considerations when using these other types of radiation planning scans. One is how to delineate the edge of tumor with PET, where there's a lot of, they're not clear-cut edges, but based on thresholding. And with MRI, of course, it's more subject to patient motion. It's a little more complex to implement in a clinic, but it does offer the very nice soft tissue resolution and the ability to use many different sequences like diffusion-weighted imaging, which have been shown to help delineate benign versus tumor-involved tissue. In addition to use of improved functional imaging to delineate the tumor, there are active studies looking at functional imaging to identify tumor heterogeneity. For example, it's been shown that hypoxia as detected on F-meso PET is associated with local regional failure. There is one actively ongoing trial in Germany where patients undergo a F-MISO PET to detect regions of hypoxia, and those regions of the tumor are then dose escalated and given more radiation. So for example, the picture shows that this area, as outlined in green, was an area that was deemed to be more hypoxic as judged by a PET scan, a F-MISO PET, and that was boosted to 80 gray instead of the usual 70 gray. Other groups are using PET scans using FDG avidity to boost those areas of potential treatment resistance. And this trial from the Netherlands, ArtForce, is a randomized phase 2. And they will be boosting some of the areas that are more than 50% of the maximum uptake. So other groups are exploring additional tracers, and the key question will be whether these changes in radiation and boosting some of the potentially resistant areas of the tumor are going to translate to improved outcomes. Image-guided radiation therapy is also being used much more commonly in most clinics. And what that really refers to is taking an image of the patient while they're in the treatment position before the radiation is given. And different imaging modalities can be used, whether it's KV imaging or cone beam CT. Some groups use fiducials. But the main idea is that a quality image is used and then compared to the scan that the radiation plan is designed off of. And what that really allows is for us to minimize the extra margin that is put on our targets to account for daily variability in the patient's setup. Because despite the very tight mask that patients have to wear, there is definitely going to be, in the range of millimeters, changes in that patient positioning. So I've shown here an example from our clinic. This patient had a recurrent ethmoid sinus tumor, had already had radiation, and had recurrence right between the orbits. And we wanted to really minimize the margin used for setup variability. And the top image here is the cone beam CT that was taken. And then the bottom part, I've sort of fused them together just to give you a sense, is the CAT scan that the radiation was planned off of. And you can see what is done on the treatment table before the patient gets the treatment, they're shifted so that the alignment is as close as possible and really on millimeter level precision. So you can see here the grainy image is the cone beam, the more clear is the initial image used for the planning, but that how nicely the patient is set up. And this again really translates to normal tissue sparing. One additional innovation I'd like to speak about at this point before going into speaking about other modes of radiation is adaptive replanning. And this is a very interesting area of research in radiation and acknowledges the fact that there is change in patient and tumor anatomy during treatment. Patients lose weight and bulky tumors shrink, and that this can lead to a reduction in dose to the tumor or an increased dose to normal tissue. So adaptive replanning really refers to the process of adapting the radiation plan to changes in patient and tumor anatomy that occur during treatment. And here's an example from our clinic. This patient had a bulky nodal disease from her head and neck cancer. And on the right, you can see her initial planning radiation plan. So outlined in red here is one of the bulky nodes. And everything encompassed by the yellow line received the high dose, 70 gray. However, in 3 weeks, a good thing was that she had very nice tumor response, and you can see the tumor is now shrunk, smaller than the initial red outline. If we had not replanned her, her radiation dosing would now look like this, where there's much more of this yellow high dose spilling out into uninvolved parts of the oral cavity. And so we did replan her. But while the concept is very simple, simply replan and try and really adapt to the changes in the patient and the tumor, in practical reality, it can be quite tricky. There are no well-defined criteria for which cases should be replanned. It's often a subjective assessment. It can be very resource-intensive. And it's not clear how to adapt the tumor volumes. Should we just shrink up our initial tumor volumes to conform to what we see the tumor is shrunk down to? Well, tumors may not shrink down to a single nidus, so we risk missing the tumor. A lot of groups are working on algorithms to automatically adapt the radiation volumes to changes in anatomy. But that is an area of research, and the gold standard of whether such algorithms are really working is to make sure that we're not missing tumor by shrinking down the volumes. So we've seen a little bit about the role of imaging, monitoring patients during treatment, incorporating better diagnostic and functional imaging. I'm going to speak now about SBRT and about particle therapy. So SBRT, stereotactic body radiation therapy, is a mode of delivering radiation that takes advantage of precise setup and imaging and gives very high doses to well-defined tumors with narrow margins. So there can be a narrow therapeutic window because you're giving high dose and there is that risk of normal tissue toxicity. But SBRT has a substantial amount of literature, especially retrospective, some phase 1 and phase 2 studies in the setting of re-irradiation for unresectable recurrences. A recent phase 2 study from University of Pittsburgh came out in combination with cetuximab and with fairly low toxicity, which is the key, less than 10% grade 3. And at Dana-Farber, we have opened a clinical trial, which is a phase 1 dose escalation study in the unresectable recurrences in patients who've had prior radiation. Another use, which has been published on primarily nasopharynx cancer, is using SBRT to boost persistent disease shortly after a patient finishes their initial treatment course. So, for example, a month after treatment for nasopharyngeal cancer, boosting areas of residual disease. Excuse me. One other application, which has been at least presented in abstract form, is using SBRT as a boost for high-risk definitive cases. For example, high-risk oropharynx cases, using it as an adjunct to IMRT to boost the tumor and try reduce the risk of local recurrences. But what will be important, again, especially in the definitive setting, is really minimizing the risk of extra toxicity. So the last few slides are on particle therapy, and that has received a lot of attention in the lay and medical press, especially with regard to protons. And this table provides you a general way of thinking about potential the characteristics of particles and their potential clinical advantages. It shows that one has to think about the biologic effectiveness of the particle, meaning the radiation damaging effect of the particle, and then the physical characteristic, meaning the dose fall off after it deposits its maximum dose in the tissue. For photons, which is how most patients are treated, these are electromagnetic waves, and when they deposit the maximum dose in tissue, there is an exponential fall off of dose. And I'll show you a picture of that. Protons are felt to have similar biologic characteristics of photons do, so they're not used because they're more biologically damaging against tumors, but more because they have a sharp dose fall off once they hit their target. And the advantage here is potential for normal tissue sparing. Carbon ions, which are really being used at a few centers in Japan, China, and Europe, have a much greater biologic effectiveness than protons or photons, but also have the benefit of the sharp dose fall off that protons have. So these have potential for radio-resistant tumors near critical structures. And most of the data, and there is some phase 2 data, is really in the setting of tumors like mucosal melanoma or some salivary malignancies that have traditionally been thought of as radioresistant. Neutrons also have a very strong biologic effectiveness, but don't have that same physical characteristic of sharp dose fall-off. So the concern there is really the very narrow therapeutic window, and there is some data of using it in unresectable salivary malignancies. So here is another graphical way to understand the physical differences between protons and photons. The x-axis is the depth in tissue, and the y-axis is the relative dose. And the dark line here is the photon going into tissue, and when it deposits its maximum dose, there's a fall-off of dose beyond that. However, the other peaks show protons of various energies, and once they reach their maximum dose in tissue, there's a sharp dose fall-off. And here is an example in a patient showing that physical difference. On the left is a single photon beam. So again, photons are how most patients are treated, treating an unusual lacrimal gland malignancy. And this is a single beam coming AP, and the orange outlines really the dose that's prescribed. So beyond that, you can see this relatively low dose that's exiting out through the rest of the brain, so unnecessary dose to the brain. Protons, however, here's a single beam going straight on, and after it hits its target, there's really no major trail-off that is going into the uninvolved tissues. So protons still, though, do have a lot of research that is ongoing or needs to be done to realize the true benefit of maximizing conformality and really reducing normal tissue. And IMPT, a slightly more sophisticated way of delivering proton therapy, is really considered to be sort of the true potential when delivering proton radiation. So most proton centers use what's called passive scattering, where a single beam comes out and is scattered to create a broader beam. And there are also these patient-specific apertures, which I'm showing below, brass apertures and lucite range compensators that are needed to conform to the target. With beam scanning technology, the beam is scanned across the patient using the special sort of magnetic scanner. And it avoids the need for patient-specific hardware and has the potential to make the treatment more conformal. So here is an example of how normal tissue is spared. The figure on the left shows IMPT with protons in treatment of a tonsil cancer. And on the right, you see IMRT. Now, both of those figures show that the red, which is really the high dose conforming around the tumor, is fairly similar. However, you can see here that the blue is all this low dose spilling out into uninvolved areas. So that really highlights one of the key differences. As I was mentioning, IMPT, so intensity modulated proton therapy, really holds the potential for realizing the clinical gains in protons, but there is still work to be done to even optimizing that. And a lot of that research has been done with colleagues and collaborators at MGH, where they looked at how the spot size of the beam can affect the conformality of the tumor. So here is a nasopharynx tumor outlined in red. Here is IMRT, so that's standard management with photons. The medium dose is encompassed in blue, and the yellow outlines the low dose. In the middle is the IMPT with protons using a spot size, the size of the beam, that's being used in most proton facilities. And you can see that while the low dose, the yellow, is actually a little less, the medium dose is actually a little bit more. So the IMRT is actually a little bit more conformal than the IMPT, and the optimum conformality or shaping around the tumor comes with the smaller spot size. So in addition to optimizing the spot size and the delivery, There's also a growing recognition of the increased sensitivity of protons to the variation in tissue density. So things that I spoke about, such as image guidance and adaptive replanning, are going to be very important. In terms of clinical data, most of the data on protons is retrospective. There is some prospective data, and this has come out from MGH recently, a phase 2 study looking at toxicity outcomes after treatment for nasopharynx cancer, which has been favorable compared to historic controls. And MD Anderson is now leading the first randomized trial comparing IMRT and IMPT for oropharynx cancer. And the primary outcome there is toxicity. So I hope I've showed you that technology and its innovations are one facet of how radiation oncology is improving the therapeutic ratio in head and neck cancer, how to maximize efficiency and use diagnostic and functional imaging to really avoid missing the tumor, allow for dose escalation, and to really try and minimize toxicity, which we see in a daily basis in the clinic, to try and reduce the amount of normal tissue. So I think I'm over, but I'll stop there. Thanks.
Thank you for that wonderful talk. So we're going to save questions until the panel discussion. Let me introduce our third and final speaker this morning. It's Dr. Mark Grinstaff, a professor here in biomedical engineering at Boston University. Those of you who know, of course, Mark is a leader in nanotechnology and the translational applications of that. And he's going to be talking about nanoparticles for imaging and, I think, drug delivery.
That's great. Good morning. Thank you very much for the introduction. It's great to be here, and I thank the organizers for the opportunity to share with you some concepts that are ongoing in nanotechnology. And in particular, I'm going to use a case study from my own lab looking at expansile nanoparticles for imaging and drug delivery. Now, there's a number of reasons why someone would be interested in a nanotechnology system, for example, for drug delivery. And you can think about them as ways in which you can maybe target a particular site so that you get more drug there and maybe reduce the systemic toxicities. One can think about using drugs that are actually very difficult to deliver. There's a lot of examples of cancer drugs that have poor aqueous solubility and therefore need to be formulated in such a way that they can be delivered. One can imagine that you might be able to improve the overall pharmacokinetics of the system. Finally, you can provide controlled and sustained delivery. Maybe the drug that you're delivering is actually a cell cyclic dependent drug, and therefore giving a dose all at once is not going to be as efficacious as giving it over, let's say, 30 days. One can think about, again, limiting these systemic side effects. One can think about increasing the drug half-life. So again, it's all about getting the right dose, the right location for the correct duration of time. And obviously, you can protect it from the environment. So let's say you are delivering a compound that's actually readily degraded. Again, packaging it in a nanotechnology type of system might allow you to get better performance. If we think about the different platforms that are used out there, there are things such as drug nanocrystals, there's liposomes, which are based on phospholipids. There are micelles, so small surfactant molecules that come together that give you like a solubilized core. And there are more complicated polymer structures called dendrimers, where things might be embedded in the inside or covalently attached. And finally, we can think about those systems that are nanoparticles that are composed entirely of polymers themselves. Now, several of these have actually been commercialized. So this is just not something that's written on a paper, but there are real examples that are being used. There's a couple examples of nanocrystals that are being used. Likewise, some liposome formulations are used in the clinic. And finally, Abraxane, which is this nanoparticle that's basically a drug coated in an albumin sphere. And this certainly gives some precedence for us thinking about how to develop systems that are going to be effective. And my interest is in nanoparticles. And so these could be typically solid, they're colloidal particles, and they can be anywhere from 10 to maybe several hundreds of nanometers. You can synthesize them out of a variety of materials. So it could be a metal, it could be a ceramic, it could be a polymer. And their size and surface properties will very much dictate how they influence with the body and the resulting efficacy and their performance. And my particular interest is in polymer-based ones. And within the polymer nanoparticle field, I have a place in my heart, a special place for stimuli-responsive materials. So these are materials that are going to go to the intended site and perform a function, and that function is going to improve the delivery capabilities. And I'm interested in pH, using that. And one can think about a variety of different types of responses. You can think about something that degrades. You can think about something that might swell. You can think about something that maybe changes its composition, so it goes from maybe being hydrophobic to something being hydrophilic. Or you can imagine it kind of inverting its shape. And I'm interested in systems that can actually swell. So I want to make a small particle, have it go to the tumor, and when it gets to the tumor and only at the tumor, have it swell and then release the contents. And that's why we call these expansile nanoparticles. And so basically in the initial state, they're, let's say, 100 nanometers. They're very small. They're hydrophobic. They're going to be taken up by the cancer cell. Once they're taken up by the cancer cell, they're going to go into the endosome. The pH is going to drop just a little bit, and that's going to cause a chemical reaction to cause these particles to go from 100 nanometers to 1,000 nanometers. Water is going to rush in, drug is going to come out, and the goal is to get a high local drug concentration at that tumor site. Well, the way we make these is the same way you make oil and vinegar emulsions at home. We have two phases, an aqueous phase and an organic phase. We shake it up, we emulsify it. You make small little droplets, and we basically cross-link the polymer in that droplet to make a solid sphere. And then the idea is that when the pH changes and becomes acidic, it's going to swell from, let's say, 100 nanometers to 1,000 nanometers. The actual polymer that we use is a little bit complicated, but the most important part of this molecule is shown right here. And this is on the polymer backbone. And when you make a small particle of this, this group here is sensitive to pH. And at pH 5, it's going to be cleaved. And you're going to get these two hydroxys. Well, now I've gone from a hydrophobic structure to a hydrophilic structure. It's like a sponge. We can make a similar control one, which is shown in the bottom, very similar structure, but doesn't undergo this hydrolysis mechanism and doesn't expand. And so again, we can call these expansile nanoparticles. Again, they're easy to make. We can do SEM, we can do TEM, we can do dynamic light scattering, and we can make particles that are, let's say, about 30 nanometers up to maybe 200 nanometers. And one of the first things we wanted to do is to see if they actually expand. So in dark blue, in the dashed line, is a formulation of these particles that are about 100 nanometers. And I'm looking at the dynamic light scattering as a function of time and pH. And the dashed line is when we have it at pH 5, pH 5. And we see that the diameter increases, so that would be consistent with it expanding. I take those same particles at pH 7.4, that's a solid blue line, we don't see any change in diameter. My control particles are in red, and neither at 7.4 or pH 5 do we see a change in size. We can also look for that group that came off during the expansion by HPLC, and again we see the same types of trends. So this is really suggestive that in fact we have a small particle. When it hits a lower pH, it expands to about 1,000 nanometers, and that's responsible. But you could be really critical and tell me, Mark, it's DLS, it's light scattering, maybe that's not so good. We got lucky and was able to do TEM. So on the top left is a solid particle at pH 7, and then 3 days later at pH 5, it's got this hollow corona. So you see the solid sphere, and you see this nice pattern on the outside, which would be consistent of a hydrogel structure. And so again, consistent with the idea that you make something solid and dense, and then something that's not dense and very broad. You can also do freeze fracture TEM, and below on the left is 7.4 at 24 hours, and you get these small little things. But on the right is 24 hours after pH 5. And in fact, this looks like a balloon and you paper mache'd it and then took a picture of it. Right? So again, consistent with this thing kind of expanding and going from there. Now, the drug of interest is paclitaxel, and we chose that because it's used in used for a number of cancers, and has low solubility, so it needs to be formulated. And in fact, one of the downsides of using paclitaxel is about 0.5% of the dose actually reaches the target tissue. So I think the problem, at least at one aspect, is as simple as that. You don't get enough drug there to actually be efficacious. So of course it doesn't work, and of course you don't get the outcomes that you want. If we take this drug and we encapsulate it into our particles, in the dotted blue line is our expansile nanoparticles, and we see at pH 5, the drug comes out, because drug is on our y-axis, the release, and again, x-axis is time. At pH 7.4 is our solid blue line, and the drug doesn't come out, whereas the control particles in red and PLGA particles, the standard polymer particle used a lot, they both leak. So in fact, the systems are leaky. And I think what's more important here is the fact that you hold on to the drug and get it to go to the site and then release than to have a leaky system. So it's both about delivery as well as about maintaining it in that formulated state. If you take these particles and you apply them to a variety of different cancer cells, you can find that, in fact, sure enough, they're toxic with drug in there. No big surprise. The solid blue line on top is empty particles. They're not toxic. But the drug-encapsulated ones in light blue, PACs, ENPs, are toxic. All right? And, of course, all the other controls are toxic as well. Now, we haven't done very much in your area of expertise, but we've had a little bit of success in breast cancer. And I'm going to share that result with you just to have you think about the types of problems we like to think about and how to go about solving them. So obviously, you know, it's a very common cancer in women, and treatment is really a combination of surgery, chemotherapy, and or radiation. It's based on staging. We know from a couple clinical trials done in the Far East that about less than 1% of systemic drug remains in the patient breast tissue after 24 hours. And 48 hours, you can't find anything in the lymph nodes. So again, I would say that clinically, we know we're not getting enough drug at that site. And so it's really about how do we improve on that and make a difference. Well, for this particular project, our hypothesis is really, can we locally administer these nanoparticles at the site of the tumor, and can we think about treating that site where the tumor is, but also the draining lymphatic system? So in vivo, I need to come up with two models. I need to first show that we have some lymphatic trafficking occurring, and second, I need to know that if my drug particle can actually inhibit the growth of either a beginning tumor or an established tumor. And if we could do that, we can maybe think about changing or adopting procedures that are ongoing. So the first part, what about the in vivo models? So what we're going to do here is we're going to prepare a nanoparticle that has two dyes on it. One dye is covalently attached to that, and that's going to be coumarin. And the second dye is going to be encapsulated within. That's kind of like our drug. And then we took a large animal, in this case the pig, and we did an injection near the breast nipple. And then we were able to follow this using near-infrared light. And what's really cool is we're able to inject and see that lymphatic pathway. It's about, I think, about, how far did we go? About 40 centimeters here. So this is really the first example where someone's done nanoparticles over a long distance in a large animal. You can easily see it. You can dissect it out. And then you can do your imaging. And sure enough, you can show that the particles are there in red. The image is not so great, but it's there. And you can see the payload in green. And in fact, they co-overlap. So one of two things happen. Either they both stayed together and got to the site, or our encapsulant and the polymer separated and they both ended up at the same place. I kind of like the former one, okay? But we could think about either way. All right, so that suggests that if we do an injection, we can enter into the lymphatic systems and we can get to that lymph node. Now, for a tumor model, the first one we're going to look at is basically to inhibit growth of microscopic primary tumor burden. So this is an easy model. So all we're going to do is we're going to inject subcutaneous, in this case, a triple-negative breast cancer cell line. And then we're going to inject one of our treatments. And then we're going to look for assessment of tumor. Okay? And what we see on the left side is, of course, tumor volume on our y-axis and weeks after treatment. Saline, of course, is in red. The tumor grows. In green is paclitaxel given systemically. This would be an IP injection. The tumor still grows. So again, coming back to this point that really you can't get enough drug at the site that you want. If we do a local injection, which is in orange, or we give our PAX EMP, both of those are much better. And the difference there is just barely statistical, but it's right on the edge. Okay? And if we look at our tumor doubling rates, again, we can see a change there. If we go to a little bit more challenging model, and that of an established tumor. So again, now we're going to take our mouse, we're going to inject the tumor cells, we're going to grow up the tumor, and then we're going to then do the treatment. And again, saline, IP, paclitaxel, local paclitaxel in our EMPs. And again, with saline and the PACs systemically, those are the green and red, we see rapid tumor volume growth. The PAC-CE in this case doesn't work so well, and the PACs EMPs work a little bit better. This is a single dose. So obviously the thing that you want to think about is doing multiple doses, but it certainly gives us some data and some confidence that this type of system is worth exploring. So what about at the lymph nodes? All right, so if we actually isolate the lymph nodes, and then we actually quantify how much drug is there, we see a striking difference. So the first picture on the left just shows you that, in fact, if we label the particles, do the injection, it'll go to the lymph node, we can dissect it, and we can image it. And on the right, we see the differences in paclitaxel drug concentration at that lymph node. And it's quite large. All right, so again, if we can get the drug there, we think we have a chance for a better outcome. And in fact, if we look at the overall metastatic rate here, again, same type of animal model, we see a reduction in that rate of metastasis. So again, very supportive of the system of using these nanotechnologies to deliver a particular drug to a site and then to increase our drug concentrations there. And so with that, I'm going to wrap it up with some conclusions. So we have a unique mechanism of delivery where we had this intracellular expansion. We know our nanoparticles are pH dependent, and that pH dependency is what gives us our delivery. We know they can localize to tumors. I have some other data, we can talk about that. We can get high concentrations of drug in the tumor. We have efficacy in a breast cancer model, and we see in vivo metastasis is reduced using this type of nanoparticle treatment. These particles can travel and migrate through the lymphatic system, meaning that we can think about treating that disease there. And then it's not only in breast cancer. So we have examples in lung, mesothelioma, and ovarian where we see very similar trends and the same outcomes. So it's just not a single thing that worked once. We think this has broad applicability. The clinical implications here, I'm a big fan of localized delivery. I think any time that you can reduce the systemic side effects and get maximum dose for the right time at the right location, you'll have the best outcome. I think the lymphatic pathways are a really interesting way to think about treating these types of diseases. And again, if we can avoid the morbidity or limit the morbidity from standard radiation chemo, that would be great. And current treatment is really limited by low drug levels in tumor. And I think that's something that we can tangibly go after. And again, this local administration for tissues or for treatment of tumors and soft tissues is critical. I didn't do any of this work today. I have a wonderful group of students, postdocs, and fellows. I'm incredibly grateful for all their hard work. On this project, Aaron Grissett was the first graduate student that actually made this nanoparticle. It took him about 3 years to come up with the design and do the characterization. And that's been followed by Kim and Aaron. All of the cancer work and the models have been done with Dr. Yolanda Colson over at Brigham and Women's. Bob Padera has been our histologist, and Vicky Herrera here over at BU has helped us on a lot of the imaging. Funding from Coulter, NSF, and NIH. And again, all of you for your kind attention today, and I'd be happy to answer any and all questions. Thank you very much.
Thank you, Marcus. Wonderful technology, very cool talk. So I'm going to ask you and Dr. Margalit maybe to take a seat up at the podium or at the chairs, and we're going to have a hopefully relatively good question and answer session now. I recognize we're a bit behind schedule, and you're probably all very hungry for lunch, but I encourage you guys to ask questions of both speakers. Very different talks, but the theme here is, getting therapy where it needs to go, whether it be radiation or drug therapy, using fairly novel technologies and approaches. So I open the floor. Please use the microphone for questions.
You mentioned paclitaxel as an example. Can you comment on other drugs, or in particular, I'm interested in antibodies and whether you could use this technology for antibody therapy?
Sure, great question. So it highly depends on the nanoparticle of use. So certainly there are examples out there in the literature where people have been able to do what I would say more of like what I've shown today, so a hydrophobic anti-cancer drug like paclitaxel. Camtothecin would be another class of compounds in that range. People have also been able to do hydrophilic compounds, so cisplatinum would be a classic one there. And there's just starting to be more work done on the antibodies and protein delivery side. That's a little trickier because of stability issues, but that is certainly an area of interest, and there are people who've actually been able to make formulations that work. The one I shared with you today would not work for that case, so that one is particularly good for the small molecule hydrophobic type of molecules.
Other questions, please, to the microphone.
Nanoparticle, I want to ask a technical question. So how did you encapsulate that hydrophobic Paxetal into hydrophobic nanoparticle?
Yeah. So in the process to make these, we do an emulsion, mini emulsion polymerization. And so we have those two phases. One was an aqueous phase and one was an organic phase. And so what we do is we put the precursors for the polymer in the organic phase along with the drug. And therefore, when we do the encapsulation process and the formation of the particles, the drug is trapped there in that process. And so that allows us to both get good encapsulation efficiency, usually above 90%, and be able to show that the material is there and then subsequently use it. Okay. So it all comes down to the techniques for which you do for the encapsulation.
What if you use a hydrophilic material?
It will not work for this way of doing it. So again, the polymer composition, and as you correctly noted, the process by which you would make the materials at the end will dictate which types of molecules you can use and what types of materials you could use.
All right, thank you.
Let me, while others get up to ask questions, let me ask Dr. Margalit a question about her talk. One of the things that intrigued me was the use of PET scanning and looking at metabolic activity in the tumor as a guide for the radiation therapy. Obviously now we're entering this era of precision medicine using molecular profiles to guide at least most of the therapies we use in lung cancer and some other cancers. What's known now about molecular markers that predict radiosensitivity broadly, maybe head and neck cancer, I'm not sure how much is out there, but broadly now for using precision approaches to guide who may be a better responder to that modality?
Right. I think, Peter touched on it a little bit this morning, but they're not a lot of great predictive markers. The best we have is P16, so is a marker for being HPV related. And really that's the primary molecular marker that is predictive and prognostic. How we use it in the clinic is really not well defined right now. It's a subject of trials about whether it's safe to de-intensify treatment. For example, in patients who are minimal smokers, P16 positive, so HPV related. Even people that receive cetuximab, that's not based on using, EGFR expression as a predictive biomarker. So really there's a complete dearth of predictive biomarkers except for P16. Don't know if there are other experts in the room who'd like to comment, but that's a huge area that needs a lot of improvement.
What about in other cancers? I'm just moving outside of head and neck. Are there other paradigms that we can draw upon from where radiation therapy is guided by molecular?
Radiation specifically. I'm trying to think. I mean, at least in terms of head and neck, it's really what we use is P16. But using molecular molecules as a predictive biomarker for radiation, not that I can think of in other settings, especially as it has been done in terms of molecular targeted systemic therapy.
Right.
And it's often, our concern more for patients who have mutations in DNA damage response genes that we're more worried about toxicity. So, but in terms of response, not that I'm aware of.
Okay, thank you. Questions?
I have a question regarding the nanoparticles. One of the problems that I know we are having at MIT Langer Lab is the translational part of creating new polymers and conjugating things that would cause a very lengthy FDA cycle. And I would love to know if you had interactions with FDA regarding creating these creative ways of nanoparticles that can target, but yet they are not on the list of safe materials, and if there is any room for FDA to make these the process shorter, so we could deliver these type of polymers, nanoparticles, to the market faster.
Ooh, that's a loaded question. So certainly Langer has an example of one that's in commercial development, as you probably know. I think it's with all things. I think what FDA is concerned with is knowing exactly what you're using and the purity and the safety of those materials. So I can imagine that if you're making for example, a new natural, let's say it's a new natural product, you need to know everything about that chemical structure, its biological activity, and how you would produce it. I think those same metrics are being applied to nanoparticles. So it comes down to how well you know your material and how well you can characterize it. One of the problems that's out there in the field for targeting is that there are not good ways of targeting. And so when you do a targeting, and you make a targeted nanoparticle, for example, maybe some of the particles have 2 ligands on it, some have 10, and some have 20. And that distribution is of concern or of question. So I think it comes down to finding ways in which you can make materials that are well defined enough so that you feel confident in the composition that's there. And I think that's probably key. One of the things that we've done in my lab is try to take advantage of systems that we can make as simple as possible with the idea that we can get them to the clinic. I think a lot of the beautiful work done in nanotechnology where they have 10 different things attached to a particle that will do everything, I think is very beautiful, but not clinically relevant. I think if you actually want to make a difference, I think you have to be smart and clever and come up with systems that you think might actually make it to the clinic. So I think it's important to think about all of that in the process.
Thank you.
So Mark, let me follow up then. The local delivery idea I liked, and I think for head and neck cancer makes sense because the disease is relatively easy to get to. But for other cancers like lung, where you can't easily deliver something locally, do you see this type of therapy working systemically? Is there a way to target the tumor cells, and how do you avoid toxicity in non-tumor cells?
Yeah, so I would say there's a whole group of people trying to do exactly that. The reality is, I should never say this, but the reality is that was what was done in the 60s in colloidal science showed that you could do an IV injection of a particle, and about 90% of it would go to the liver, for example, and still the same today, you know. So I think it's all about how do you go about addressing cancers where you might be able to use local. So lung is tricky, but you could imagine in early stage lung cancer where they did a resection,
Sure.
maybe you could apply it at the margin.
Right.
So I think there might be selective areas where it could be very powerful, and I think we should try to take advantage of those opportunities. I think head and neck is another nice area for that. I think the other challenges that are for IV, I think, are very worth pursuing, but I don't think we have really brilliant answers yet for that. So I think there's an opportunity for basic research as well as an opportunity for getting something into the clinic.
Great. All right, well, if there are no further questions, let me thank both speakers for excellent presentations. And